Well, hello again. Welcome back to Advanced Human Gross Anatomy. Today's dissection, number 21. We'll talk about the orbit and the eyeball is our focus today. So this might be a little shorter one, which is probably fine for you. This is a fairly significant dissection, though. Today it's a fine dissection. We'll be doing a lot of detail work inside a small space. So I want you to take your time and really make this dissection crisp with your attention to the detail. The orbit has a lot of adipose tissue, so actually a surprising amount of adipose in it. So when you're dissecting, you're going to be pulling this out. You'll spend a lot of time removing that from the orbit with a forceps, pinching and kind of grabbing it to get it out of the orbit itself. And we'll focus on this in this dissection on the nerves, the arteries, and the muscles in the orbits through the frontal plate there. There's a lot of veins. There's a big plexus of veins in this area as well. And I'll give you permission to just remove them. If you see a big plexus of veins, you can take those out. Those won't be our focus today. I'd rather focus on the nerves, the arteries, and the muscles within the orbit. So let's start with just a review of the orbit itself. Here you can see the skull and then a closer up version. I think this is going to serve us better to see this bottom picture here. Looking at the zygomatic bone, which is this kind of orangish bone here on the side. This makes up most of the lateral wall of the orbit and some of the floor of the orbit down here. The maxillary bone, which is, you can see it larger up here, it comes all the way down the top of the roof of the mouth, coming around the side here. It's actually a split bone. It's not fused. It's not one bone. There are two of them. But on each orbit, this is going to be the majority of the floor of the orbit and some of the nasal cavity, kind of on the inside here, medial aspect. The lacrimal bone, which is purple right here. This is that really small, thin bone, smallest bone in the skull. It makes up part of the medial wall of the orbit. There's that depression in the middle here for where the lacrimal sac would sit that we talked about previously. The ethmoid bone sits right behind it here. This is part of the medial wall behind the lacrimal bone here of the orbit. Sometimes it's called the lamina papyracea, which is a term meaning a paper-thin layer. It's very thin through here. On the other side of this, we'll see in a few moments, are these ethmoid air cells. So that make up what we call the ethmoid sinus. It's on the inside of that. Behind there then is the sphenoid bone. This makes up a bunch of the back wall, the posterior aspect of the orbit. Has a few things that we're familiar with already. The orbital, the optic foramen or the optic canal right here coming into the eye. This is where the optic nerve, cranial nerve number 2, and the ophthalmic artery are going to come in toward the eyeball. They're exiting the skull here. And then you've got this superior orbital fissure. Remember, that's just right underneath that lesser wing of the sphenoid and the greater wing. On that ridge there, you'll see from the inside of the skull that we've looked at in the past is the superior orbital fissure. Now coming out of here, remember, is the ophthalmic division of cranial nerve number 5, V1 branch of 5, the oculomotor, trochlear, and abducens nerve, all three nerves innervating eye muscles that we'll look at with greater detail today. Also, the ophthalmic vein is exiting through here. And the inferior orbital fissure right down here between the maxilla and the sphenoid bone. There are some smaller branches of the maxillary artery and nerve that will exit here, and then they'll enter the face. Sometimes you'll see here, you can see the infraorbital groove. They'll be sitting within that. Sometimes bone will cover that completely. This will vary on the body itself within the orbit of each individual person, how much bone is accumulated there, but they'll travel through that groove or maybe through the infraorbital canal there, and then exiting the infraorbital foramen as the infraorbital nerve and artery here. We won't necessarily get to see a lot of this today underneath the eye, as we're not going to expose it because it's more underneath the eyeball. So we'll probably leave that alone mostly, but you'll see the nerve exiting the infraorbital foramen for sure. more about the ethmoid bone here. If you take another look at the ethmoid again, at the top of the ethmoid, between the ethmoid and the frontal bone, are these two holes right up here, the anterior and the posterior ethmoidal foramina. These are found right at the top here, right underneath the frontal bone. This is right, remember the top of the ethmoid bone in the skull is the cribriform plate on each side of the crista galli. So there are branches, and we'll see this later on as we talk about the nerves going through here, but there are branches of the nasal ciliary nerve that travel through these ethmoidal foramina. The anterior and posterior nerves will travel through the anterior and posterior ethmoidal foramina, as well as some branches of the ophthalmic artery as well. And what they're doing is they'll go from the ophthalmic artery coming through the optic canal here. They'll branch off that ciliary, nasal ciliary nerve and artery will come up into these anterior and posterior ethmoidal foramina. They'll come into that top of the cribriform plate and then drop down into the nasal cavity to help supply some of that nasal cavity. So we'll pick these up later as we look inside the nasal cavity. And then the frontal bone, obviously the frontal bone is a big one up on top. This is the superior portion, the roof of the orbit, if you will. The orbital plate is what we found looking down into the skull from on top. Now let's look at some of these paranasal sinuses. We've talked about these in the past, but again, we're talking right where these are today again, so we'll review these. Here you can see the eyeball looking straight in from a lateral view here, a sagittal view. Here's that little sinus up on top, the frontal sinus, this hollow space within the frontal bone above the orbit. Here you can see the maxillary sinus, hollow space below the orbit. So if you have sinus pressure, oftentimes you'll be pushing towards the kind of the underside, the top side of your eye. That's because these spaces are getting filled. Unfortunately, that's where the pressure is getting built up there. If we take a cross-sectional view here. There we go. So this is a transverse section through. Here would be that lamina papyracea, that the lacrimal bone here of the orbit, and then that ethmoidal bone here. And I said just on the inside of that, this paper-thin layer on the inside of these ethmoid air cells. And so here's where you're going to see that labyrinth of spaces that make up the kind of that lateral nasal cavity, that lateral nasal wall here. So we call those the ethmoidal sinuses. And then the sphenoid sinus is right behind that. Think of the body of the sphenoid being hollow right on each side. So the sphenoidal sinus within the body of the sphenoid. So notice how the eye in this picture too, it's interesting how it's kind of coming laterally. It's going posterior to anterior, but medial to lateral. It's kind of shooting out at the edges here. So the other eye would go out towards the kind of laterally here from its origin within the orbit. I think that's interesting. Now in today's dissection, what I'd like us to do is we're going to gently break away the orbital plate. Here you can see how that's been done here. Looking down at the anterior fossa of the cranial cavity, we're going to break through this orbital plate to get to the structures below it. So gentle taps with a hammer and chisel in this area. We'll start to break away some of the bone there, and we'll use a nippers and a forceps to remove those bone fragments just so that we can create this nice cavity that's open here, breaking through the frontal bone on top of the orbit. Okay, now I'll have you do this on both sides, on each side, obviously here. For two eyes, you've got two eyes to look at, so let's just take a look at all the structures here. Maybe on one eye, you would focus on the arteries and the muscles, and on the other eye, you'd focus more on the nerves, or however you want to distribute that, trying to disrupt as little tissue as possible. Remember, dissection is to separate, not to mutilate, so just be careful as you're dissecting here. I'd also like you to remove the dura on the middle cranial fossa here as well. And this is going to expose some of the nerves here, cranial nerves 3, 4, 5, and 6. 3, 4, 5, and 6. Here's abducens is right here. So 3, 4, 5, and 6 coming down. And that cavernous sinus. We should be able to see that. Also, this will help expose the the carotid artery. Here you can see it kind of peeking through, and then the ophthalmic artery as it branches off of that to go towards the socket as well. So we'll take a look at that. Okay, now let's go through some of the nerves that we'll be able to identify here. The trochlear nerve. Let's start first with trochlear. The trochlear nerve number here, cranial nerve number 4, is going to branch off right through here. This is going to supply and innervate only one muscle of the eye. Okay, you can see how it's kind of looping around here. It's going to loop into this muscle here called the superior oblique muscle. This muscle is interesting because it's going to come around and then go through a pulley here called the trochlea. That pulley is the trochlea. So the trochlear nerve goes through the trochlea. That makes sense, right? It supplies a muscle that goes through the trochlea. So on the top, this muscle goes on the top of the eye, alongside the nasal cavity, right here, and then it goes through that trochlea. And then loops back around the eye. Here you can actually see it's been cut in this picture, but you can see how it's going to loop back and around the eye from front to back, from medial to lateral. So its function, can you see what it would do if it's going to pull this way? This is looking top down, obviously. It's going to rotate the pupil down and out. This muscle, and it's innervated by that one nerve. You can see it's a thin nerve, very small nerve, the trochlear nerve, as it comes around here. So we'll hope to identify that nerve and muscle today. The frontal nerve, everybody's going to find the frontal nerve right away here. It's a branch off of the ophthalmic division of cranial nerve number 5, right here, V1. It lays right on top of the orbit, so once you break through that orbital plate, it'll be staring right at you. This splits, you're going to see how it splits here into the supratrochlear and then ultimately the supraorbital nerves. And here's where we've seen these leaving the orbit already. We've seen them kind of come up onto the forehead as they leave. So that's what this nerve is. The ophthalmic branch of the trigeminals, one of those big nerves coming off of that is the frontal, which splits into the supratrochlear and supraorbital, sitting right on top of this muscle here called the levator palpebrae superioris. So let's talk about that one next. This muscle right on top, this big muscle here, again, it'll be looking at you right, looking at you. I didn't mean to give that pun there, but it's right as you break through the superior orbital plate. So it lays right underneath the frontal nerve. That's how you'll identify this. And it descends down. Let me go back to this picture here. You can see here's that levator palpebrae superioris coming right down onto the eyelid. It will help to lift the eyelid upon contraction here. At the distal end of it here is actually smooth muscle. This is called the superior tarsal muscles. These are autonomic. It's an autonomic muscle. This can cause, if it's fatigued, it can cause the eyelid to droop a little bit. Some people have kind of that droopy eyelid. That's the superior tarsal muscle, which is just a distal extension of the the levator palpebrae superioris on top here. So that's that muscle there. Let's go back here to this picture. Now, branching off of V1 again here is the lacrimal nerve. This nerve is again coming off of the ophthalmic division of cranial nerve number 5. It's a very thin nerve laying right on top of the lateral rectus muscle, which is outside here. And this nerve is going to continue to the lacrimal gland. So you'll be able to see that. It is on the upper outer part of the orbit. So you should be able to see that in today's dissection here. The lacrimal nerve sitting on top of the lateral rectus muscle. Now, the muscles here, let's look at a different picture here. The musculature, we've seen the trochlear muscle here, superior oblique muscle, which is what the trochlear nerve is innervating. There's the superior rectus muscle, which is cut right here, but that's this muscle right up on top. It's going to pull straight. The rectus muscle, the superior, inferior, medial, and lateral rectus muscles are pretty self-explanatory. When the superior rectus contracts, it's going to, the pupil will travel up when it contracts. The inferior rectus, you can see on the bottom here, when that pulls, the pupil will pull down. It will travel down. The medial rectus on the inside, when that pulls, it's going to rotate the eyeball medially. The lateral rectus, you see here, it's been cut to identify the optic nerve, but when that one contracts, it will pull the eyeball laterally. So the only two funny ones here are these oblique muscles. So we've seen the superior oblique muscle here, pulling the eyeball down and out. Now we've got to have one pulling the eyeball up and out. Now what's interesting about the field of vision is that there's a lot of overlap in our field of vision between the two eyes. The area between the eyes is pretty well covered by what the other eye can pick up. If you closed one eye and put your hand kind of at the medial aspect of where that vision was and then open the other eye, there's a lot of overlap. Now the area that might need a little more help or a little more attention are the up and out and down and out. If you're walking through the woods and you need to look up into the trees or down into the bushes, these are muscles that might help with that. So you can see this inferior oblique muscle here is going to be helpful with that as well. That's going to help pull it up and out. So at the bottom of the eye, traveling again from front to back, medial to lateral, here's where it attaches. That's going to pull, and you can see how that might pull the eyeball up and out. Okay, so superior oblique up and down, down and out. Inferior oblique is up and out. They're just kind of opposite of what their names are for their actions. They're named for where they are, not what they do. That might help you identify those. So now on one eye, as you go into this picture again here, on one eye, you might need to go a little deeper to get to some of this other stuff here that we're going to look at. So maybe identify some of the superficial structures on one eye, maybe some of the others on the other. So a branch off of V1 again here. Let's look here. Off of V1 are these nasociliary nerves right here. These are going to be laying on top of the medial rectus muscle. So here's medial rectus. They're going to be underneath the superior oblique. And here you can see how they're going to send nerves through this anterior and posterior ethmoidal foramina. So again, these are going to, in here actually, in this picture by Netter, you can see how they're coming through, especially the anterior one, coming through, going over the cribriform plate and then descending down into the nasal cavity to help supply some of that area. So there's a nerve and an artery in both of these places. We'll learn the nerves in a little bit. That are in these places. So going through the anterior here and the posterior ethmoidal foramina. Now they also continue on. There are these long ciliary nerves that continue on to the back of the eye, right through here to the eye itself, and then the infratrochlear nerve is going to continue. So that as the posterior nasociliary and anterior nasociliary nerves are going to come here. Posterior and anterior ethmoidal nerves are going to come in through there off of the nasociliary nerve, and then they continue on to become this infratrochlear nerve as it comes down. That's going to innervate some of the skin on the eyelids, the conjunctiva, the lacrimal sac, some of that area here through that infratrochlear down this way. Okay, now abducens nerve, this is going to lay directly it's going to supply the lateral rectus. Remember on this picture we saw the lacrimal nerve sitting right on top of the lateral rectus muscle. Here you can see Netter's got this little probe, this little blunt probe, and he's pulling that lateral rectus. Here you're seeing abducens nerve laying on the medial side of the lateral rectus muscle. So I think about the the trochlear nerve innervating the superior oblique muscle because it goes through the trochlea. Think about the abducens nerve innervating the lateral rectus because it's going to abduct to the eye. That's how I would remember that. That's only going to innervate one eye, abducens, cranial nerve number 6, innervating the lateral rectus to abduct the eye, bring it away from midline. Okay. Now, the oculomotor nerve is a bigger nerve. That's this one here, cranial nerve number 3. It's bigger because this is going to branch to all of the other eye muscles, except for the lateral rectus, which is the abducens nerve, and the superior oblique, which would be the trochlear nerve. So those two nerves innervate one muscle each. The oculomotor gets the rest of the eye muscles. Now the optic nerve you can see here, you'll have to dig down, this is kind of deep in the orbit, you'll have to find that optic nerve by going a little deeper and pulling out some of that adipose, being able to see some of those structures inside there. Passes through back through the optic foramen alongside of the the ophthalmic artery as it comes back here. Now, some of you may find in your dissection today, you may find this structure here sitting kind of right on top of the optic nerve here. It's called the ciliary ganglion. Now, if you do find this, we'll call everybody over. We'll have a big celebration there. Because it's kind of a fun thing to find. It's maybe tough to find. These it sits right, like I said, above the optic nerve here. Now inside of here, this is parasympathetic ganglion. These are nerve cell bodies of parasympathetic, postganglionic parasympathetic nerves, sending their fibers onto the eyeball. So they're going to continue through that ganglion down to the eyeball. Now, sympathetic fibers also travel through here. These are mostly coming along with the carotids, mainly the internal carotid, along with that blood supply there. But these are going to pass right through the ciliary ganglion without synapsing here before they go straight and innervate towards the eye. Remember, their synapses were more proximal than the parasympathetics. Okay, let's shift gears a little and talk about blood supply. Just a couple things to think about for blood supply. Remember the internal carotid coming right up next to the sphenoid, and it gives this branch called the ophthalmic artery here. Kind of makes that right angle, the internal carotid does, at the optic foramen, just past the sphenoid, and it gives off this ophthalmic artery here, this branch towards the eye. So branches of the ophthalmic artery, what I want you to see here, these posterior ciliary arteries here coming right down this way. Then as that ophthalmic artery continues more medially, it's going to divide here. It's going to give these anterior and posterior ethmoidal branches. Guess where those go? Right through the anterior and posterior ethmoidal foramina with the anterior and posterior ethmoidal nerves, going down through the cribriform plate again, and then down into the nasal cavity to help supply some of the areas in there. So that's where that is. And then it continues on. You can see how it just continues on to this supratrochlear artery up on top here. So going through the supratrochlear foramen and then up towards the eye as well. Which we've seen in the past. So this is going to branch here, the supraorbital and supratrochlear artery branches again off of the ophthalmic as it comes up to supply some of the face. Hopefully that's a little review, but here you can see where it's branching off of that I want you to find important. Okay, let's spend a little bit of time now as we finish up here talking just about the eyeball itself. We won't be dissecting one of these eyes off of the cadaver. I think it's better to leave the eye in so that we can see the connections of these nerves, arteries, and muscles. If we take it out, we're just going to disrupt all of that and not be able to identify some of the other structures I think are important here. So we'll dissect, in lieu of that, we'll dissect a cow eye, which it doesn't have quite as prominent of a fovea here on the retina. The difference with a cow eye here is it's mostly cones. There's not a lot of, it's mostly rods, not a lot of cones for color vision. So we'll be able to just see a little bit of difference there. Okay, let's talk about the fibrous tunic here. Tunic means coat, this outer layer. The fibrous tunic is the outside layer here. The sclera is the majority of the fibrous tunic. Here you can see it on the other side coming all the way around, and then it stops here at the cornea, which is this anterior portion of the fibrous tunic, meeting at the sclera. Now, see here that this is a cross section of the eyeball. Obviously, this is more circular. If you're looking at this straight down, it would come all the way around. We're just looking at a horizontal, a transverse section of this. The cornea is totally transparent. It is living cells, but there's not blood supply here. So if you have bloodshot eyes, that's going to be more in the sclera, not in the cornea itself. The cornea gets its nutrition, we'll see in just a little bit, by diffusion of the aqueous humor as it comes around and supplies this area with nutrition. But the fibrous tunic on the outside. Now, on the inside of that, this kind of pinkish layer here is the vascular tunic, or the choroid, it's called, this vascular tunic on the inside. Here is where you're going to get the blood supply. So a lot of that vasculature that we just talked about is going to the eye and innervating these. The blood vessels are being distributed through the choroid, right through here. This goes again all the way around the eye, except for right at the front at the pupil here. It's not just around the sides like it shows in this picture. Again, this is a circular structure. Hopefully you can see that. You can visualize that through the picture here. So it attaches, let's see, it goes all the way, it goes around the whole eye, but stops right at the lens here. Now, at the anterior portion here, through these suspensory ligaments is where the lens attaches. So the choroid attaches to the lens through these suspensory ligaments, or sometimes they're called zonular fibers right here, which anchor the lens. There's a ciliary muscle, a smooth muscle within the ciliary body right here. That's kind of this anterior portion of the choroid. This ciliary muscle, when it contracts, this is a little counterintuitive, so this is kind of weird to pay attention to, but when it contracts, it'll kind of wrinkle up the choroid body like this. It will release, it will kind of pull this way, releasing tension on the suspensory ligaments. And what that does to the lens is it kind of rounds it out. And a rounded lens would be more for near vision. Okay, so if you are getting older and you need cheaters because you can't quite see the near vision, that's an issue with this ciliary muscle right through here, not relaxing enough, not contracting enough to pull towards the suspensory ligaments, giving them slack. Now, when that muscle relaxes, the intrinsic elasticity within the ciliary body will pull on these suspensory ligaments and kind of flatten out the lens here, and that's for far vision. So the opposite can be true for that. So if you're getting laxity through the ligaments here, these suspensory ligaments or the zonular fibers, that might mean you need a corrective lens to reshape, to kind of help flatten out that lens as the light refracts through. So it's a little counterintuitive. A contraction here will actually put slack on these ligaments, and a relaxation will actually pull those ligaments away. Cataracts are when cells of the lens die inside, they create kind of a scar tissue here. There's good laser techniques they can do to kind of resurface the lens. Also, surgeries now allow us to completely replace the lens, which is just kind of awesome. You can just replace this lens with biased more for near or far vision, and give you your vision back as that happens. The iris, which is this most anterior, right in front of the ciliary body here, the most anterior portion of the choroid, again, this goes all the way around here. You can see how it's cut. This is just cut in cross-section. Here's the rest of the iris on the outside. This is what gives your eye its color. And if you've got blue eyes or brown eyes or hazel eyes, the color is the iris, which is just the most anterior portion of the choroid, surrounds the pupil. The pupil is just this space, this negative space within the iris. The iris acts like a shutter. There are smooth muscles in there as well that can help dilate or constrict to determine the size of the pupil. They can pull it out, dilate, or they can shut it down if it's brighter light. Or parasympathetic innervation or sympathetic innervation can help to determine how much light needs to come in the pupil. Now the retina is this yellow, depicted yellow here in the artist's diagram here, this innermost coat or tunic of the eyeball. These are where the photoreceptors are. And again, it doesn't just travel. It's not just cross-section here. It comes all the way around the eye. But what's interesting about the iris is it doesn't go all the way forward. You only have a retina present where light can come in. So you can see where light will enter through the pupil. That's about where it is. So it doesn't actually come up underneath the ciliary body because there wouldn't be any refraction there to happen for photoreceptors to receive. So only is going to be present where light can hit it. It's sensitive to brightness and contrast through here. Now we'll talk about some histology, but because this isn't a histology course, but we'll talk about a little bit histology. But if you look at this picture here, this would be the inside of the eyeball. Here's the choroid. This layer from behind here would be the choroid, and then the fibrous tunic would be the outermost layer back here. So we're looking in the eye. So light, as it comes into the eyeball, goes through the eye, through these cells. the ganglion cells, the bipolar cells, through the photoreceptor cells. It hits that choroid layer and then is refracted back. And you think, well, that seems odd. Isn't it kind of backwards? Why would the photoreceptor cells be the first thing that light hits? Well, that's a good question, and I don't really have a great answer, but it seems to work pretty well, so we'll just go with it. So light hits it gets blocked, and it's not allowed to go past the choroid layer here, so that it gets refracted back, and the first thing it hits is these photoreceptor cells. Now, these are your rods and your cones. Rods are going to be more for black and white, and you've got a lot more of those than you do the cones. Cones are going to be more for color vision or detail and focus. If we go back to this point here, the fovea is this point right on the back here where you're trying to focus the light for fine detail. So in our dissections, you guys are using a lot of your attention at the fovea, and there are more cones there than any other part of the retina. So this is going to be a point of the where vision is the most clear and most crisp. Okay, let's go back to this shot here. Now so these photoreceptor cells are going to synapse onto these bipolar cells, nerve cell body with dendrites coming down and axons going from it, just a bipolar cell here. And then they're going to synapse in these ganglion cells. Now the ganglion cells have axons. Once they're stimulated to threshold here, they're going to send their information through the axons. The axons of the ganglion cells actually just make up the optic nerve. That is where the information is traveling here. Now, what's interesting here, you've also got these depicted green in the artist's drawing here. These amacrine cells, these horizontal cells here. Now, why would we need these here? These help to kind of have group analysis of the stimulation from the photoreceptor cells. So we're most sensitive where contrast is, at edges and with movement. And so it's best here to link some of these multiple photoreceptor information coming into these cells that can then synapse onto these ganglion cells and kind of group data together. Now, as we show, let's go to this picture here. This is a light micrograph of the same thing. So you've got the inside of the eye through here. You've got the pigmented layer. Here's your choroid, right here, the choroid tunic or the vascular tunic. Here you've got the stained cells here of the rods and the cones, the photoreceptor cells. Here's the nuclei of those rods and cones. And then you've got these bipolar cells, which stain nicely here. And then the ganglion cells don't stain quite as well here, but they're going to be in through here, and then the axons leaving the retina, all congregating back. If we go to this picture, can't really see it on this shot, but all of the nerves that make up the optic nerve here are just those ganglion cell axons as they come back to do this. Okay, now from here, there's a couple of more things I want just to pay quick attention to. The aqueous humor, just like the cerebral spinal fluid is being produced by the choroid plexus within the brain at all times, it's just constantly being produced there and then being drawn back into the circulation through the sinuses that we learned about. You're also producing this aqueous humor within the kind of the ciliary body here. It's constantly being made in this posterior chamber of the anterior cavity. Now the eye is split. Think of the anterior cavity as where the lens is forward and the posterior cavity behind the lens. But then you've got this iris. So the posterior chamber of the anterior cavity is between the lens and the iris. And that's where this aqueous humor is being made all the time. And then it has nutrients that will help feed the cornea. Remember how the cornea does not have good blood supply. It's going to diffuse through the pupil into the anterior chamber of the anterior cavity, and then give nutrition to the cornea on the inside of the eye. And then it will as it diffuses through there, it gets reabsorbed into circulation. Now again, it's across. This picture always confuses me, and if I get confused by it, I'm sure you might too, maybe. But this goes all the way around the eye. It's a transverse section, so don't think it's just 2 points here. Here you can see it on the underside, this area where the cornea will meet the sclera. this sclerovenous sinus. And here you can see where that aqueous humor is then going to drain back into the circulation through that sclerovenous sinus on the inside of the cornea, where the cornea and the sclera meet. Now, on the back side of the lens here, the posterior cavity is this vitreous humor. This is behind it. It's a jelly-like substance. When you dissect the cow eye, you'll see this is kind of a thick, gelatinous kind of substance. It helps for the eye to maintain its shape. And so it gives it kind of a jelly distinction. It's got some viscosity to it. So during the dissection today of the cow eye, you might see, that part of the retina attaches itself. The retina tears off when the vitreous humor pulls away from it. So you might have some portions of the retina attached to the vitreous humor of the cow eye as it kind of lays on the dissecting tray. Now, glaucoma, just one little quick thing about glaucoma is when you've got an excess of aqueous humor here and not being reabsorbed back into the system here, that's going to create this pressure because it's a closed system minus where that sclerovenous sinus is. The old name for this was the canal of Schlemm. A physician or scientist named Schlemm named that one, but trying to get away from proper names. But when that's not reabsorbing that material very well, over time that pressure will increase and push back on the lens, push back into the vitreous humor, and push back into the to the vasculature, and that can compress the central artery of the retina, which is going to branch off that ophthalmic artery, and that can cause infarction of the tissues of the retina. And if that happens, ultimately that can create blindness. So glaucoma is a test they can do up the optometrist to kind of put a puff of air here to give some pressure to see if that creates any symptoms that aren't favorable. Okay, that's enough of me for today. I hope that was helpful. I hope that was nice and quick and easy. Hopefully got some new knowledge on that, or some mastery of the knowledge at least. And I look forward to seeing you in lab. Thank you for your time. Have a wonderful day.